Acute kidney injury.
We're going to talk about acute kidney injury, or also known as AKI. So there is three types of potential causes, and AKI is the acute rapid loss of kidney function, and you will possibly see a rise in the creatinine because you're going to hold on to the waste products. You're going to see a rise in your BUN, and you're going to see a decreased urine output typically. And we're going to talk about those in the phases. But in the pre-renal phase, this is damage that happens above the kidneys or before it gets to the kidneys. Intrarenal is going to be damage at the kidney level or in the kidneys. And then the post-renal is going to be the damage after the kidneys. And then we're going to talk about the different phases. And you remember the phases by oh darn renal. So we've got the oliguric, diuretic, and recovery phase. So let's dive into what is the pre-renal phase. And the pre-renal phase is basically the volume or perfusion to the kidneys is dropped. That is either due to hemorrhaging, loss of fluids, low cardiac output from an MI or heart failure, GI losses with vomiting and diarrhea. So just decrease in circulating blood volume. Your kidneys aren't damaged yet, but they are about to take a hit because they're not perfusing. And when you have a decreased systemic blood flow and you're not perfusing the kidneys, you're going to have a decrease in your glomerular filtration. So you may not see at the beginning a decrease in their GFR, but you will eventually once you start having more kidney damage. So you have to fix this. You fix it soon. What is intrarenal? That is damage to the kidney tissue, which results in nephron damage. And the number one cause is acute tubular necrosis, which is actually damage of the nephrons and the tubules of your kidneys. And most of it, 90%, from hospital, it occurs in the hospital mostly, but is from the pre-renal stage from either acute and prolonged ischemia, so not fixing this pre-renal stage, and now we've moved into the renal stage, or nephrotoxin. Nephrotoxins can be things like NSAIDs, antibiotics, and antimicrobials, some chemo drugs, or contrast dyes, or adding metformin while somebody has gotten contrast. So make sure you hold that metformin if somebody goes for CT with contrast. And also sepsis. And then post-renal, that's an obstruction or outflow blocking of the renal tubules or the renal pelvis, which is actually in the kidneys itself. And that can be from kidney stones, blood clots, benign prostatic hyperplasia, which is your BPH, so enlarged prostate, tumors. And so you got to unblock this so the urine can flow out. If you block and back up the urine, then you're not going to have an outflow. So what you're going to do is all the waste buildup, and that's your BUN and creatinine, it's going to start damaging the kidneys because there's nowhere to go. So you're going to have to diagnose this really fast. You're going to get routine labs. You're going to get a urinalysis, CBC, and a CMP. And if you're suspecting it's post-renal, you're going to get an ultrasound. That's typically what you're going to do first within the first 6 hours. And making sure you don't have exposure to contrast media. It is not the first line. You can do a CT if you suspect any kind of ischemia or problems with the bowels. So you can actually add a CT with contrast, but you may want to avoid that at the beginning. So they'll do things like a renal scan or an MRI. Then you're going to go into what it's going to look like. So what you're going to see in these when it occurs, you're going to typically see an oliguric phase, and that's the first phase. And urine output is going to be less than 400. And typical urine output for a normal person is about 800 to 1500 milliliters or cc's a day. And that equates to 30 to 60 cc's an hour. That's typical, especially if you have Foley, easy to measure every hour. 30 cc's an hour, you're good. Well, what happens in an oliguric phase? You go less than 400, and that averages out to about 16 cc's an hour. That's not good. So what's going to happen? You're going to increase in your BUN and creatinine, and you're going to see an onset typical within, if it's ischemia or low blood volume, that's going to occur very fast. So you're going to start seeing this oliguric phase within 24 hours. But if it's a nephrotoxic agent, so you're having some type of reaction and it's killing off the nephrons and the glomerulus and it's hurting your kidneys, that may take a little longer, 1 to 7 days. And if you're in ATN, which is acute tubular necrosis, you may not be oliguric. So you may actually be making urine, but you're having damage that is occurring. So it's kind of hard to diagnose people with ATN at the beginning. These people are at risk for hyperkalemia because if they're not peeing off their potassium, and potassium, 98% is excreted in the urine. So it's really important to watch your potassium levels. Metabolic acidosis and anemia is also a complication. If you fix this oliguric phase, and you can fix this, you're going to move into the diuretic phase. That's when your kidneys are trying to compensate and trying to make urine. So this lasts about a typical 1 to 3 minutes, 1 to 3 weeks, and it can last up to 3 months. You are at risk if you start diuresing about 1 to 3 liters. You can reach as high as 5 liters. You're at risk for hypovolemia, which is that low blood volume, and you're at risk for hypotension. So if your blood volume goes down, your blood pressure is going to go down, and you will see a tachycardia because your heart's going to try to compensate. And so if you are at risk, you're going to actually have a low sodium level. You're actually going to have a low potassium level because you're diuresing a lot, and you're dehydrating. And the reason why you're going to have low sodium is because you're having this massive volume loss, and your kidneys are starting to compensate, but you're not concentrating the urine. So you're not able to absorb the sodium. And so you're going to be losing the sodium, and it's not going to be reabsorbing. So you're going to have low sodium. And then if you make it out of the diuretic phase, you're going to move into the recovery phase. So this may take up to 12 months. And if you don't make it out of this phase, then you go into chronic renal failure. And a lot of older people are more at risk due to comorbidities and other disease processes where they actually have problems not recovering. So if you're going to treat it, you treat the signs and symptoms and you try to reverse it. Really watch for hypokalemia. So hyperkalemia is at high potassium level, and you want to make sure you move it back into the cells because it's floating around in the extracellular place, and it loves to live in those cells. So short-term use can be insulin and using sodium bicarbonate. It temporarily removes the potassium and pushes it into the cells. And then you have to give them some D50 because, of course, insulin makes your blood sugar go down, and you want to make sure you give them the D50. So this is an ICU type of thing where you're actually going to be treating this. But if you're in hyperkalemia and you can pull the potassium off, some other things you'll do is you would give them some type of PO potassium medicine like K-Xylate, which it actually removes the potassium from your feces versus your urine. But again, or you can give them some diuresis or some Lasix, which also will pull the potassium. So those are things that can lower your potassium level. You can do hemodialysis or continuous renal replacement. That is a dialysis that is a temporary dialysis where they can actually filter out the kidneys. And then fluids and diuretics. Again, this may be what the physicians are using as kind of like a push-pull method where they'll push fluids, they'll pull with using diuresis, trying to pull that urine, trying to stimulate the kidneys. And so these are some of the treatments. Make sure you get them on nutritional therapy, increase their carbs and their fats, and decrease their protein because that can build up in the body. All right, and that does it for this lesson. I will see you at our next session.